I'll be talking about how these refractive surgery selection can be made more appropriate from a biomechanics standpoint. And already the theme of the session is in that way. So we all know about the history and evolution of refractory surgery practice. First came the topographers, then we have few ectasia risk scoring systems, then came tomography, and of late, biomechanics has become really prominent in the last 2 decades. And, clinically, we have these cases patients coming in front of us, and this is an example of a 26-year-old female came in for a refractive surgery. These are the pentacam maps. Some of the commonly used indices like BAD-D, the Corvus biomechanical index, the total biomechanical index, all indicated that everything was okay with this patient. Mind you, just look at the refractive error in this patient, so it was of the order of like -6.5 spherical equivalent in each eye. And though all the indices seem to indicate that everything was normal with this eye, and smile was planned in this patient, and eventually it was performed, the patient did end up having ectasia post-surgery. Okay, so how can we mitigate these issues? So we focus a lot on tomography, and what the challenges of evaluating tomography can be made quite evident with this recent study from us, and this was done by Dr. Himanshu, who's also there in the chair here, and one of my team members, Matthew. And what we looked at is, for example, BAD-D, right? It is an example. It describes how the thickness of the cornea varies spatially. So from the center to periphery, if the cornea is very thin or is very aberrated, we get a high value of BAD-D. Now, what we looked at was the corneal diameter of a patient cornea, and when we measured the corneal diameter using the pentacam images at different meridians, we got this very unique variation in the corneal diameter. And what we can see is that the arrow indicates the location, meridian at which the minimum corneal diameter was, and this coincided exactly with the steep corneal axis on the anterior surface. So this was a distinct deviation from what is commonly assumed, that the corneal diameter variation for a patient is elliptical in nature. But how does this influence BAD-D, and how this can lead us to wrong conclusions about a particular cornea in terms of whether it is suspicious or it's truly a healthy structure. So once we quantify this cornea, I'll show you this one patient here. This is a 560 micron cornea, looks pretty okay. None of the pentacam elevation maps are pointing out anything severely abnormal. And when we looked at the minimum corneal diameter for this patient, which was around 10.48 millimeters, the BAD-D was 0.88. Now we go to the next patient. Again, here we see a slightly steeper cornea, but again, very comparable thickness to the previous case. The pentacam map shows that, yes, something suspicious is there, because you can see in the posterior posterior surface, you do see some example of a steeper elevation there. And when we looked at the corneal diameter, it was 9.97 millimeter in these cases, but the BAD-D suddenly increased to 2.98. And this was, in the eyes of most corneal and refractive surgery specialists, this can lead to wrong interpretations of which cornea is truly healthy and which cornea is actually suspicious. So therefore, tomography cannot be only relied upon exclusively.
So this is a very, very, very important point which Dr. Abhijit is showing. Even Dr. Himanshu was discussing that we have to look back at the scans and see what it is. We can't simply just, our refractive, as we keep doing, we just look at the colors. We have a tendency to do that. Okay, red, oh no, let's go ahead, let's avoid, just move forward. But actually we have to look, why is it red? Is it genuine? See the corneal diameter. Because this, if the fitting is different from what the normal, what it's comparing, then we can really have wrong interpretation, and then we might tell the patient something else. Please go ahead, Dr.
Oh, thank you. So, like Dr. Naren correctly pointed out, that it can lead to a wrong interpretation. So why is this physiologically important? We talked about genetics. This is what exactly happens, that you can have two corneas. So I've just drawn it schematically with the yellow and the slightly orangish line. And you can see that if the corneal diameter changes, the same cornea will become steeper. Okay, and therefore, just the tomography alone cannot be relied upon, and this is where biomechanics comes into picture, because biomechanics is not only just the shape, it is also a function of the strength of the tissue, and also how much refractive error you are treating in a particular patient specific to a particular type of surgery. So this is where we started working upon. We did a lot of computer simulations, biomechanical models, and we looked at patient-specific collagen architecture, and we incorporated all of this into sophisticated biomechanical models, which could be used for prediction of what would be the biomechanical stiffness of the cornea after surgery. And these predictions were specific to the Corvus ST device, which is currently being marketed by Oculus. Now, the problem with this models where, this is all okay to do in the research domain, but this has to be brought into the clinical domain. So we set up on the task of making a custom software where we have our own proprietary finite element simulation models. We do 3D geometry reconstruction. All this is incorporated in the software. And in this software, we also include what would be the type of surgery that you would like to do, how much ablation you would like to perform. And combined with sophisticated AI models, we come up with predictions of the post-operative corneal stiffness of a particular patient. Now, keep in mind that all this simulation is done at the preoperative stage. This is not being done at the post-operative stage, because we are trying to use the software to decide which surgery would be ideal for the given patient. And so this is, so this is how the software looks. It's very simple, intuitive to use, and it can be run on our standard OPD machines. In fact, in our hospital here in Dr. Rohit and Dr. Himanshu's clinic, they are running it in their usual computers on a day-by-day basis. And if you looked at how this software performs, so this is a comparison of what what was measured in a set of eyes, which is over to 529 eyes exactly in this case, on the y-axis, and what the software predicted. And what you can see is that there was a very good correlation, and in fact almost 1:1 correlation between what was measured and what the software was able to predict. And the red dots that you see there on the plot, these are actually patients that have ended up with ectasia. So we got an excellent accuracy in predicting which patients would probably end up in having ectasia. And we have come up with a nice decision-making nomogram based on our results, and this is probably one of the largest data sets included in the software of patients who actually ended up with ectasia that can assist you in deciding which surgery to perform. So this is a very short video of how the software works. It's very simple. You open it up, select the type of surgery that you would like to simulate, use the Pentacam elevation and the Corvus ST measurements, include what are the different thicknesses, flap thicknesses, the surgery-specific parameters, what spherical cylindrical coordinates. We also have a function to include the uniform epithelial thickness. We can include a spatially varying thickness, but that's dependent on what the surgeon requires. And then once the simulation is completed, we give a nice report. And we also give a kind of a guideline to the guidance to the surgeon with respect to the decision nomogram that you saw in the previous slide. So with this, I'd like to conclude, and I would like to thank our multicentric collaborators here, Dr. Prema from Shankar Netralaya, Dr. Ricardo from Italy, and in-house, we already have Dr. Rohit, Dr. Himanshu, and several other past and current fellows who have assisted in this project. Thank you.
Can I congratulate you on a very interesting concept?
Yeah.
I have never been happy with Corvus. I think many doctors have not been happy. Yeah. It's really a glorified tonometer, not truly measuring biomechanics. I think the one element that we have found so difficult, as did Dupes and co., and that is the cornea is a dynamic system. Mm-hmm. And with patient heartbeat, it's interacting at the limbus with the sclera. So the actual peripheral curvature changes with your heartbeat. Yeah. Unfortunately, the position of the corneal apex moves with heartbeat, but not the curvature. So it's going to be very interesting to see how good your finite element model is in terms of cross-correlating in a dynamic system.
Yeah. So to answer this question quickly, and probably we can talk about this more, the Corvis measurement is over just around 30 milliseconds. Okay, so it's quite fast. Secondly, in our model, we do include the scleral curvature also. So we do have an extension from the corneal limb is extending in the model, so that we model the globe effects in the deformation. Okay. So far, what we have observed is that the effect that you're talking about, which is the pulsating due to the heart motion, is really doesn't get captured in the Corvis purely because of the time scale of the measurement.
Only because you haven't been using a pulsimeter. If you use a pulsimeter, you'll actually see there is a significant effect. You're probably just
correct.
You're just integrating it out.
Yeah,
you're losing it.
Yeah. So in the duration of the measurement is just not as dominant as what you. Yeah.
So one background about the thing about white-to-white measurement. Many years back, I used to tell Abhijit that as a cornea surgeon, we know that microcornea are steeper cornea, smaller cornea are steeper cornea, but they are not ectatic cornea, right? They are by shape steeper. However, as a refractive surgeon, anything steep we call evil, we call bad, we call them ectasia and everything, which was not true. Hence, in refractive surgery, whenever there were cases like this thing shown, where the bad D became sort of a gold standard, which was based on the regular corneal diameter. A smaller corneal diameter which has, so how does that happen? A finite amount of corneal tissue has to be accommodated into a smaller diameter, hence it becomes steeper in the possibly embryologic period I'm talking about. When the opening is larger, the same amount of tissue gets flattened because it's a larger opening. And that's as simple, in simple term if I have to explain. Now, what we realized that these smaller diameter cornea were showing steepening, but were they actually weaker cornea? If they are weaker, we will surely not go ahead and treat them with the refractive surgery. But if they were not weaker, then we are possibly depriving many of these patients from, or we are rather unnecessarily labeling them as an ectasia. And that's the reason, that's the background, how we started measuring it. And then we found out, and not only this thing, we could actually estimate the exact corneal astigmatism from the corneal diameter, white to white diameter, including the excess of the corneal astigmatism, and which was very fascinating. And that's how we started developing the model of corneal diameter and curvature. And then we realized that smaller diameter cornea are not necessarily weaker cornea. So in meetings, when we talk about, we forget about asking, or rather as the speakers, we forget about mentioning what was the corneal diameter before we talk about this case was bad and this case was good.